So it's almost time, and the time is very limited, so I'd like to start the next session. Well, hello. I'm Takahiro Suzuki from Kitasato University in Japan, and I will chair this session. And the session is on the classification of MDS, and I will welcome the speaker, Dr. Rafael Bejar from the United States. And he's an associate professor at the UC San Diego Morris Cancer Center, and he's a member of the WHO Classification Committee. So the title of his today's talk is Review of the Two and More Classifications. So Dr. Bejar, would you start your talk, please?
Excellent. Thank you all for the invitation to be here today and the amazing day that we had yesterday visiting multiple temples and shrines. I've already done my 2 hours of morning meditation, so I'm prepared for giving the talk today. And I'll be speaking with you about the novel MDS classifications. And you've already heard snippets about these in the earlier talks given today. My focus will be on the differences between the two and how we can move forward. Disclosures. The two parallel classifications do represent a significant change from what we had in 2016, but they aren't perfectly aligned, and I'll share some of that with you. One of the aspects that they have is they now have some novel definitions for entities that weren't specifically recognized before, some of which are shared and some of which are not. There have been several interesting attempts to validate the clinical value of these schema, and they shed some light on maybe how we could get to a path towards reconciliation. So let's start with the WHO 2016 guidelines. The classification system is shown here. And I think what really stands out to me is that there really are only two instances where we're using a molecular or genetic feature in order to define a subgroup. And in my mind, the goal of a classification system is really multiple. One of them is to define biologically similar groups of patients within a more heterogeneous disease. The other is to find some sort of grouping that helps make clinical decisions, and that could be a prognostic value or some other merit that helps you identify a targeted therapy, for example. But we do understand that the biology is driven by the genetics, and therefore this is a good way to get a look at what some of these features might be. The way that I like to visualize it instead of that list is this slide that Dr. Surgeon shared with me, is to think about it as being into three different groups. Those individuals that have 10 to 19% blasts, those individuals that have 5 to 9% blasts, and then those individuals with low blasts that are differentiated, obviously not by the blast count, but by other morphologic features largely, like MDS with single lineage or multilineage dysplasia, MDS with ring sideroblasts, and of course the MDS with del5q is the sole genetic category in that group. Now, what do we have with the two classification systems? I'm not entirely sure of what led us to this point. We know that the two groups of people that helped design these things were largely not overlapping. They were mutually exclusive, and as you mentioned, I was on the WHO committee. I had the privilege of seeing it from that side. And I think despite the fact that these groups worked largely in isolation, it's relatively surprising to see how much similarity there are between the two classification systems. I think the goal of both of them was, as I described earlier, to have a more molecularly defined approach wherever we had the data to support it. And it's surprising to me how many decisions were made in the same direction by both groups. It's also important to understand that many of the characteristics of the WHO 2016 were maintained, so that for many patients, the classification would remain the same, and it would be even the same in both of the new systems. But there are some significant differences. Some maybe account to just nomenclature, but even that can be controversial. There are some differences in diagnostic criteria where some patients are in one group but not another, and there are some new entities that are only present within one classification scheme. So I think in the meantime, we will have to use both, especially if we want to have some retrospective ability in the future to have this data put together at the time of diagnosis. So what have we done with the new classification scheme? So I'll go back to that picture of what the 2016 guidelines look like, and then show how the WHO has updated in 2022. We still have the three major columns designed by blast count, where 10 to 19% blasts. It now, instead of being MDS with excess blast 2, is with increased blast 2. 5 to 9% is MDS with increased blast 1. And for the less than 5% blast, those low blast cases, we have a new category, MDS hypoplastic, again, largely because we've identified a group that maybe isn't biologically distinct, but it has some potential avenues for treatment that are more likely to work in that group. We have MDS with low blast, now lumping together single and multilineage dysplasia, And we have MDS with SF3B1 as a new category that's genetically defined. However, we maintain the MDS with ring sideroblasts, and I'll show you how that may cause some issues. We have the old MDS with del5Q, and we have another new category, very relevant to Dr. Daver's talk about MDS with biallelic TP53 mutation, and this is irrespective of the blast count in MDS. And finally, the WHO also has a group for those patients that do have increased blasts that deals with MDS with grade 2 or 3 fibrosis. Now, what about the ICC? The structure is still very similar. We have these 3 groups based on blast count, but the nomenclature is different. We have the 10 to 19% blasts with MDS AML, which I'll talk about in greater detail, no longer being called excess blast 2 or increased blast 2. 5 to 9% blasts are MDS with excess blasts, and the less than 5% blasts are still single lineage dysplasia, multi-lineage dysplasia, the new category MDS SF3B1, but you'll see there's no MDS with ring sideroblasts as a subset of that group. MDS with del5Q stands, and we also have this multi-hit TP53 category that is irrespective of the blast count. So given that we do have some more molecular features, where does morphology come in? And I'll say it's still very important that those clinical groups that I just described are probably only about 20 or 30% when you define them by genetics. We still need dysplasia of 10% or more in any particular lineage as a MDS-defining morphologic feature, and only in those genetic subcases are morphology or dysplasia less relevant. Single versus multi-lineage dysplasia is a difference between the 2 groups, as I mentioned, and even in the ICC, where we don't have an RS subgroup, it still is important to look for ring sideroblast as a morphologic or a dysplastic feature, and of course, because it's relevant to the label of some drugs that are used to treat MDS. Here's an example of the survival difference of patients with single versus multi-lineage dysplasia. So at least from a prognostic standpoint, it makes sense to separate these 2 groups. If you're thinking about it from a ontology group or biology phenotype, maybe not. Maybe you put them together because the biology is heterogeneous regardless of how you look at it, but there is a difference there. So let's take a deeper dive in the SF3B1 and ring sideroblast categories. So mutated SF3B1 now replaces most cases of MDS-RS, and that's true for both groups. The single versus multi-lineage dysplasia is not relevant in either the ICC or in the WHO, although there may be a difference there even within this category. And there are certain other abnormalities like del5Q, abnormalities of chromosome 7, complex karyotype, MECOM rearrangements, that would exclude a patient from being in this MDS with SF3B1 mutant group. The ICC does require a VAF of 10% or greater, and also requires that patients not have a RUNX1 mutation or multi-hit TP53 to be in this group. And this is a more biologically homogeneous entity than the previous category of MDS-RS, and in the ICC at least, the ring sideroblasts don't play a role in assigning a patient into this group. Here's the way that I like to think about what we've done. This is the category of patients who would have been called MDS-RS under WHO 2016, and this group is very largely overlapping with those subsets of patients that have an SF3B1 mutation. Most of these patients are both ring sideroblast positive and SF3B1 mutant. In the ICC, what we've done now is really focus on the SF3B1 mutation and identified those patients that have at least a VAF of 10%, capturing most of the patients in the old SF3B1 mutant group. And then the remainder of patients who might have ring sideroblasts are just stratified in the MDS single lineage or multi-lineage dysplasia. And I'll show you the contrast with what the WHO does. While the criteria are very similar with the WHO, there is still no distinction between MLD and SLD. You cannot have chromosome 5q abnormalities, chromosome 7 abnormalities, or a complex karyotype. RUNX1 is permitted. SF3B1 mutation cannot have a P53 mutation, however. But here, the WHO has retained that ring sideroblast group for those individuals who don't have SF3B1 mutations, but have at least 15% ring sideroblasts. And this is quite different from what you would think of as a typical MDS-RS group in the WHO 2016. So here's what that would look like in the novel system. If you have any SF3B1 mutation, regardless of the allelic frequency, but don't have any of those other exclusionary criteria, you would be in this group for WHO. So it's a little bit of a broader group. But those individuals that have ring sideroblasts and no SF3B1 mutation are in this new, I would say new, or subset MDS-RS group that's quite heterogeneous. So the value of this may be questionable. So the question is, how do these individuals do compared to maybe patients who are in that same low blast category who don't have ring sideroblasts? And there is some difference of opinion in different studies, but largely the survival is very similar. So whether having an MDSR as subcategory is useful from a prognostic standpoint is less clear. And the IPSSM also handles SF3B1 in a much more nuanced way. It's not simply a favorable finding. It really depends on the genetic context in which it occurs. So in the context of co-mutation with del(5q, it's actually more adverse than you might predict an SF3B1 mutation might be. And that's one of the reasons for excluding the del(5q patients from that subgroup. The other, of course, is that they have another place to go in the del(5q subgroup. And then the SF3B1 co-mutated patients that have adverse mutations in RUNX1 or NRAS or STAG or SRSF2 also don't do very well. They have an inferior survival. And those patients are, again, somewhat excluded from the group, at least in the ICC if they have RUNX1 mutations, but not entirely. Fortunately, 80% of these patients or so have what we call isolated SF3B1, would be considered MDS with SF3B1 mutation, and do have a more favorable prognosis. So now let's change gears and talk about the TP53 mutation category. You just heard a great talk from Dr. Daver about this and about the challenge of identifying whether or not you have single or multi-hit and how important is the VAF and so on. So I'll highlight what the ICC and the WHO did to try to reconcile some of this. We know that TP53 mutations do have some very unique biological features beyond just having a poor prognosis, typically associated with complex karyotype, actually associated with fewer co-mutations in other genes, often seen in therapy-related disease, and of course, very high rates of relapse and inferior overall survival. And as Dr. Daver showed, and Elsa Bernard demonstrated, that there is this massive difference in survival, at least in MDS, when you think about multi-hit versus single-hit TP53. So the ICC has created this group, the multi-hit TP53 group, where you have to have a VAF of at least 10% for a TP53 mutation to be in here. It supersedes all other MDS phenotypes, including those with or without excess blasts. And it spans a large range of the blast, but it also includes patients who have biallelic TP53 inactivation, which is not very well defined. How is it that you know that based on the data that you have? Of course, if you have a VAF greater than 50%, you can infer that mutation's biallelic. If you have two distinct mutations with intermediate VAFs, you can assume that those are likely independent events. They're not in cis, and they're biallelic inactivation. If you have abnormalities of chromosome 17p, then you can make that assumption as well, but it's often hard to tell. And there are emerging data now that even in patients who have low VAF TP53 mutations, single-cell work could even identify that some of these are biallelic in those patients, and they do have an inferior prognosis. Now, getting to the AML portion, this new group of MDS AML, for example, what both groups, the WHO and the ICC, have done is recognize that some patients that we might have called MDS in the past really have much more AML-like phenotypes. And Dr. Bernard this morning actually showed how there are AML-like mutations in MDS, and those patients don't do very well. Well, some of these in the future will just be AML if they have at least 10% blasts in the ICC and have some of these chromosomal rearrangements like KMT2A, DECNUC214, MECOM, and so on. That isn't a requirement for the WHO. If you have one of these abnormalities, it's presumptive AML regardless of the blast count, much like we do with some of the other favorable translocations. AML with RUNX1 is gone, and there are some other differences in how we define AML that I won't go into now, but just to say that there are some patients that are no longer MDS are now in the AML category. But I think most controversial was the creation of this ICC category called MDS AML that was created for those individuals with MDS and 10 to 19% blasts. My interpretation of the rationale for this is that there's a biological continuum between MDS and AML, that having an arbitrary 20% threshold really didn't make any sense, that if a person had 19 versus 21%, they obviously have the same biology. The other question, of course, is what have we done by simply lowering that threshold down to 10% now, where we have another boundary to deal with? But the rationale for this was that maybe some of these individuals with high blasts in MDS could benefit from some of the therapies that are now emerging in AML, especially if they share certain biological features. And I think this has been misinterpreted to some extent as to say that everybody with 10 to 19% blasts should now be considered as a potential AML patient and treated as such, or at least give consideration for that treatment. I still think it comes down to the biology, because this 10 to 90% blast is still a very heterogeneous group. And I'll go into some examples of that in a moment. Now, shortly after these came out, several groups ran to their tissue banks and their databases to see what it looked like in practice. And I think there's some lessons to be learned from here. This is from a Chinese group that looked at almost 1,000 subjects that were stratified using WHO2016 and remapped to the ICC 2022. And what you can see in this river plot is that most of those lines are horizontal, meaning most patients landed in a group that was very similar to the group that they came from, without a significant shift, even if that group might have been renamed. There are some lines that do cross widely, and those are usually patients who are now in novel genetically defined categories like TP53 group or MDS SF3B1, and of course the MDS unclassified before, which no longer exist in either of the two systems. They had to travel somewhere else. And we look at the survival of these different groups defined by the ICC in this data set. There's some important lessons to be learned here. At least in this Chinese group, the MDS SF3B1 patients had very similar survival to MDS with single lineage dysplasia. That was better than the survival in those with multi-lineage dysplasia. And we looked at individuals with excess blasts, whether it be 5 to 9% or 10 to 19% in this MDS AML category, they had very similar and obviously inferior overall survival. The P53 mutant patients unfortunately had the worst outcomes, and it didn't matter, again, whether they were in that MDS category or that MDS AML category. Having that TP53 mutation status conferred the worst overall prognosis. A similar study done in part out of Moffitt showed very similar findings. This is a more Western cohort, and in this case, the MDS SF3B1 patients, which are a greater proportion of the patients, have a slightly better survival than the MDS single lineage dysplasia, which is better yet than the multi-lineage dysplasia, as I showed you earlier. And if you look at the TP53 mutant patients, again, regardless of the blast count, their outcomes are inferior and much to the left on this curve. If you look at patients with IB1 or IB2, this is 5 to 9 versus 10 to 19% blasts, their survival is also not very different either, suggesting that the difference of 10% blasts, that arbitrary threshold, is arbitrary even within the confines of what we call MDS. And finally, whether or not a person has MDS EB1 or MDS M, or whether they have AML, the survivals are actually very closely grouped together, suggesting that any form of excess blast really puts you on the continuum with AML, as previously described. So how does this look in a diagrammatic fashion? As we have increasing blasts, we go from MDS to AML. The difference that used to be 20% blasts now may lie as low as 10% blasts with this MDS-AML overlap category in the middle, at least according to the ICC. But on the other side of this, we have pre-MDS or MDS-like conditions that don't quite meet the diagnostic criteria. And the distinction here still remains dysplasia. So looking at the bone marrow is still going to be a very important characteristic for understanding these patients. And the WHO and the ICC had identical definitions for what CCUS should be. It looks very similar to the CHIP definition with the presence of an unexplained cytopenia. And CHIP, of course, is a much more prevalent condition, although I wouldn't call it a disorder. And the distinction between CHIP and CCUS is that unexplained cytopenia. As I mentioned, the diagnostic criteria for both are the same. And I think it's really important as we start thinking about how to understand these individuals better and what the risk is of going forward. But I think of all the definitions that were created, this is probably the one that's most likely to undergo some more clonal evolution. Pardon the pun. Expect future revisions of these criteria to include high-risk features for both CHIP and CCUS, some of which may actually now fall into the umbrella of being called MDS, in much the same way that we now include genetic abnormalities even in patients who don't have sufficient dysplasia. There may be different VAF cutoffs for different genes, which were not incorporated into this definition, and like I mentioned, more MDS-defining profiles. So where do we go from here? Different groups have, I think, adopted different versions. The ALN really has adopted the ICC criteria. The NCCN mentions both, but recognizes WHO criteria. The IPSSM, which was actually created kind of in parallel and before them, incorporates some features that both have looked at. And Amar has done a great job of bringing the community together to think about what these differences mean in terms of where we can go in the future, and also to think about how we need to actually apply this in practice, how we need to understand which patient falls into which category. And I think this has gotten a strong sense that reconciliation is truly needed. Then there's some interesting studies that actually look at the value of some of these different groups. And this is one that I found really interesting that looked at the MDS-AML overlap subpopulation and compared it to what we do with AML normally, for example, stratifying by ELN risk classification. And what they found is that if you apply the IPSSM to those patients with MDS-AML, you stratify them quite well. You can see these different lines are corresponding to 5 different risk groups here, suggesting that this is a very heterogeneous group with this MDS-AML category. And if you apply the ELN criteria and define these as being intermediate or adverse, there were no favorable leukemias in the MDS-AML overlap group, almost by definition, given the types of mutations they tend to have. The outcome was much better for the MDS-AML group than it was for the corresponding risk group in the AML category, suggesting that there is a distinction. Of course, if you just took the average of survival of MDS-AML compared it to the average survival of AML, they look very similar, but that's because we don't have any favorable patients at all in the MDS-AML group. So the argument here is that this distinction of MDS-AML really isn't necessary, that these patients are still MDS-like in many ways, especially in terms of their mutational status. And then when we think about applying AML therapies, we should think about it based on biology. Do they have the targeted factors that would recommend that therapy in an AML patient, for example? Do they have other clinical features that might suggest they do better with AML-type therapy, like having AML-like mutations, DDX41 or NPM1 or other things of that nature? Another validation system that looked at a large number of patients comes from Düsseldorf, where they confirmed that there are important prognostic differences in the WHO2022, both in those patients with high-risk type features like IB1, fibrosis, and so on, and in the patients with low blasts and low-risk features. And they looked at both systems and thought maybe there is a path forward, there's a way to reconcile these, and some of those include combining SF3B1 and RS into one group, where you then subspecify whether or not a patient has an SF3B1 mutation, whether or not a patient has multi-lineage or single lineage dysplasia. And then they also acknowledge the controversy around how you define the TP53 mutation status, that in some studies, having one mutation in more than 10% blasts confer an equally poor survival to those patients that are multi-hit. And in others, there's more ambiguity, suggesting that single hit really is better than having double hit, even in patients who have elevated blasts, and certainly in patients who have low blasts. So they recommended recognizing both, that you would have a subgroup for biallelic TP53 alteration, but for those high blast patients that have a single hit, you would create a separate group there, understanding that they may be different and important to identify as we go forward. So a potential hierarchy that they recommended begins with MDS, pulls out the bilateral P53, and then only after that divides patients based on blasts, identifies patients with low blasts in the different subgroups that we've mentioned, creating this combined SF3B1RS group, and then pulling out the mono P53 in the high blast group as another group to follow, followed by fibrosis, IB1, and IB2. I think it's an interesting model, and we'll wait to see what happens. Of course, given Dr. Bernard's talk this morning, perhaps by the time we get around to doing this reconciliation, we'll have new molecular subgroups to consider, and maybe a reconciliation isn't really what's needed. It's an evolution into another program. So with that, I'll finalize, and I'll save time for questions. Thank you.
Thank you, Dr. Bejar, for your interesting and very comprehensive talk. So now this session is open for questions and discussions, but time is very limited, so the chairman welcomes a very quick question and quick discussion. Then, okay, please.
Okay, Rep, nice to meet you. I'm Jason Chen from the University of Chicago. So actually, I have a couple comments or critics on the WHO, ICC categories. I think, to be honest, I'm not very, actually, I disagree with some of the changes. I think needed to be really amended. For example, ICC categories, there's one entity called MDS without dysplasia. This should be dropped because simply that entity does not exist. Okay, because you have to have something diagnosed as MDS. You just have cytogenetic molecular morphology. So there's no categories MDS without dysplasia. because that's automatically, without dysplasia, automatically you classified as MDS with cytogenetic or molecular abnormalities. So that category does not exist. So should be dropped from ICC. I really recommend amended and this ICC to drop that entity. Secondly, I brought this a couple times. I don't want to be a pain in the ass.
Excuse me, but time is very limited, so one question, please.
Oh, okay.
Okay.
Okay. I yield to other people's. I do have another question. Another question about GMML. I don't think it's appropriate to put into myeloproliferative neoplasm, because if you put that one, there's a lot of cases, -7 case, you have to remove that cases, and that doesn't make any sense to me. So we have this discussion, I mean, once Dr. Vardaman was in the office. Anyway, yeah, to my
Thank you for your thoughts.
Okay, then Dr. Miyazaki, please.
You mentioned that the WHO 2022 introduced hypoplastic MDS. And you didn't mention about the distinction between aplastic anemia and hypoplastic MDS. How do you think about that?
Yeah, that's a great question, and that's still a debate today, that how do you distinguish aplastic anemia from hypoplastic MDS when you have very few cells to look at if you need to establish the presence of dysplasia? So in my opinion, you shouldn't necessarily settle that question before you decide what you're going to do for the patient, that if you have ambiguity about whether it's aplastic anemia or not, you may consider presumptive treatment. But the genetics can help us to some extent, and Yarg, who was with us earlier, has published on this, where certain mutations are much more indicative of an MDS-like future for a patient, and much more likely to progress to MDS, and maybe should be considered MDS at the outset. And other mutations predict response to immunotherapy. So when you look at, for example, deletions of HLA alleles and so on. So I think we don't have that well defined in the classification schemes that have been presented to us about how to make that distinction, but I think there are paths forward on how to do that better.
Thank you. Then next, please.
Yeah, great talk, Bejar, as usual. So the question is regarding the patients who have more than 20% plus. Again, similar to what I asked earlier, I don't understand the concept of thinking of this as a continuum only when it's less than 20%. There are some patients who are like, but why are we not saying the same thing for patients who are 20 to 30% who are behaving more like MDS, and how was that conclusion made in both classifications in that direction?
No, that's a great point, and that's something that Alcinelli looked at in the IPSSM. They included patients with 20 to 30% blasts in their analysis to see, and those patients stratify fairly well with the IPSSM also, suggesting that that heterogeneous group also has MDS-like features that are important in terms of prognosis. So I don't think we should have that arbitrary threshold. I think for ICD-9 purposes, maybe you should, but you should think about a 25% blast patient as a patient who might benefit from more MDS-like directed therapy potentially. The problem, of course, is that right now most of the therapeutic options are coming from the AML side. Very few drugs that we have available in MDS that we don't have in AML, Aztecs being one of them, but only for a few more months. So I don't think that that distinction matters so much. I think they're right to say that it's a continuum, but it does definitely expand beyond 20%.
Thank you.
Okay, thank you very much. So now time is very limited, so I'd like to close the session. Thank you very much, Dr. Bejar.